Now we're doing hypertrophic cardiomyopathy. Patient come with dyspnea on walking, and he has a previous history of cardiac disease. Also, father had a heart condition. This is pulse is 100 per minute, which is high and jerky in character. BP is low, mean hypotension, 100 over 60. Respiratory rate is normal, 20. Double apical impulse, and there is short systolic murmur, which is mid diastolic murmur, which is because of the aortic stenosis, and there is a pan systolic murmur, which is because of the mitral regurgitation, and S4 is also audible. Clinical features includes family history of a sudden death, exertional dyspnea and exertional angina, jerky pulse, double impulse at the apex, and S4 is palpable. Mid-diastolic murmur due to aortic stenosis and pan-systolic murmur due to mitral regurgitation. It is the most common form of cardiomyopathy. It is characterized by inappropriate left ventricular hypertrophy, malalignment of the myocardial fibers, and myocardial fibrosis. Pathogenesis includes is genetic disorder, autosomal dominant type, a single point mutation in one of the genes that encode sarcomeric contractile proteins. There is three mutations. Beta myosin heavy chain mutation. It is associated with ventricular hypertrophy. Troponin mutations. It is characterized by myocardial fiber disarray, exercise-induced hypotension, and sudden death. Then there is myosin binding protein C mutations. It is associated with characterized by hypertension and arrhythmia. Then there is heart failure developed because the heart ventricles are stiff and non-compliant left ventricle. Then it has three types: generalized, septal, and apical hypertrophic cardiomyopathy. Septal also causes left ventricular outflow tract obstruction or hypertrophic obstructive cardiomyopathy and mitral regurgitation. And there is systolic anterior motion of mitral valve. Then there is clinical features, which includes symptom angina on effort, dyspnea on effort, syncope on effort, and sudden death. Signs include jerky pulse, left ventricular hypertrophy, double impulse, palpable fourth heart sound because of the left atrial hypertrophy, and there is mid diastolic murmur and pan systolic murmur. Then there is risk factor for sudden death in hypertrophic cardiomyopathy include history of previous cardiac arrest, recurrent syncope, and adverse genotype, exercise-induced hypotension, and non-sustained ventricular tachycardia on ambulatory ECG monitoring. Then there is marked increase in left ventricular wall thickness. Investigation we do is echocardiography and ECG. And on ECG we see T wave inversion and genetic testing. Management includes beta blocker, calcium channel blockers, and disopyramide. If arrhythmias are occurring, then we give amiodarone. And outflow tract obstruction in septal hypertrophy, we do partial surgical resection, myectomy, or septal ablation. Then avoid digoxin and vasodilators because it causes decreased cardiac output and which will lead to decreased perfusion. Worst prognostic factor includes younger age, male, positive family history, history of syncope, genetic mutations of arginine gene, and exercise-induced hypotension, which is worst.